Jenny Schneer is the HCUP project director with the Agency for Healthcare Research and Quality. She's going to spend some time talking about what HCUP is, a bit of the history of how it developed and some of the lessons learned. And then again, we'll take some time after Jenny finishes and move to a panel of representatives from state APCDs to think a little bit more about what that HCUP history might mean or could mean for APCDs. So with that, I will hand it over to Jenny, who's going to take us through that time. Thank you, Jenny, for joining us today.
Thank you so much. Let me just check, Joe, you can hear me and see the slides?
We absolutely can. Looks great. Thank you.
Terrific. So hello, everybody. I think the first thing I noticed in just watching all the names float across the screen is there's probably at least a quarter of the people in this group who could do the same presentation. They've been either partners or involved with HCUP for so many years. I think when we talk about lessons learned, it'll be interesting to see what the other perspectives are as well. But to get started, what I was asked to share with you is just a little bit about what HCUP is for those of you who have not been involved in the project, and reflect a little bit on lessons learned in terms of what it took to put this project and partnership together. I'm going to just do a very quick overview on the project without focusing on a lot of the smaller details, because we're not really focusing on the databases themselves, but really about the collection of information and product in databases, and the accompanying resources and how we release the data to the public. And then, as mentioned, we'll talk about lessons learned. And by the way, we're going to do this within about 15 to 20 minutes, so hang on, we're going to go pretty quick, but then we'll have time for questions. Okay, so HCUP is a federal, state, and private partnership that is a comprehensive set of publicly available all-payer healthcare data. It includes self-pay and no charge, and it includes multi-year inpatient and outpatient data based on hospital billing records. So here are the four main components. There are HCUP databases, which I'll comment on in a little bit. We have 48 states and the District of Columbia that participate with providing us inpatient data. We have 41 state organizations that provide us emergency department, and 35 that give us ambulatory surgery and services data. From those databases, which were the beginning of the HCUP project, we built tools that are online to assist others in either getting information or interpreting the data. So that includes HCUP.net, which is an online query system, FastStats, which allows us to use quarterly data from our data partners, provide up-to-date information. In addition, we have online software tools that help you to aggregate the data. I'll go through these sort of quickly later on. But we also produce research and analytics. You may have seen our statistical briefs. We have methods reports in which we share methodological findings and recommendations about using the data. And we produce white papers, and of course we provide user support to assist users in using the resource. So for those of you that are not familiar, the Agency for Healthcare and Healthcare Research and Quality is one of the agencies under the Department of Health and Human Services. I think we're the smallest of all agencies, but we're pretty mighty. But this just gives you a feel for where AHRQ sits in the scheme of HHS. And then I think the part that we're really, I think that folks here are interested in is the partnership and how that works and how that is organized. So 30 years ago, maybe a few years longer than that, preceding me anyway, I've been with the project for over 20 years, but not at its genesis. There was an effort that was made to combine resources between the Fed, state public health agencies, hospital associations, the AHA, among others, to work together to figure out how to leverage data that was already being collected across the states into a combined resource, which could then be hosted by the Fed and made available to others for research and analytic uses. And these happen to be our HCUP data partners. They are each organization comes with its own unique set of requirements. Each organization, as you all know, have different rules and regulations, whether they're set by their own department, whether they're set by the state legislature, whether they have policy groups or data release groups. All of these organizations come to the table with their own requirements and interests, along with what we are trying to do for the HCUP project. And that's a theme I'll come back to later. But most importantly, HCUP only exists because of these data organizations that provide the data to us under voluntary agreements to share the information. And on this slide, I'm just wanting to show you that not every state has all data types, but we are collecting the virtual majority of the data that's available. As I mentioned, we have all the states except Alabama and Idaho, although we continue to talk with them and they've had some progress lately that we're keeping an eye on. Okay, I think for this group, I'm not going to focus too much on how data gets created because many of you are the creators of the data. But essentially what HCUP is doing, it is collecting from the data organization in the state who is authorized to collect and to re-release the billing data that's occurring in inpatient, ED, and outpatient hospital settings. Then we accept that data in whatever format it is already collected. We are not going directly to the hospitals. We're going to 2/3 of our partners, as you saw, are public health agencies, about 1/3 are hospital associations. There's a few that are quasi-governmental. They are not government, but they've been authorized by government to be the one to collect and release information. We take the data in whatever format it's created so that there's no additional burden for us other than cutting the file to our specs. And then through our contractor and our guidance, we standardize that data to create uniform HCUP databases. Okay, just a little note to Charles or Joe. I don't think I can see any chat questions while I'm presenting, so if you need to interrupt to ask a question, let me know, or I'll just wait till we get to the end.
Okay, thanks.
So just focusing a little bit on what that process really means. So what we're doing is we're taking that state data, as I just described, and then mapping it to a standardized format, which allows for consistent data elements across states, so that you can, when using a HCUP state database from Hawaii, compare it to Kentucky, and everything is going to be consistent in terms of those variables. But we augment the data to enhance it, and so we also add value-added variables. So we might add information on supplemental variables for revisit analysis. We'll include injury indicators or indicators that show that the stay was for observation or ED services. We also add hospital characteristics to help with the analysis of the data. We provide DRGs and severity measures, and we also do quality checks. Although by and large, the data comes to us in really good shape. It's the kinds of quality problems we discover now are not very great, and they're not very frequent, but typically it may occur more where there's a new vendor involved or there's been a change in the system and it's the first time they're creating that resource. But we do obviously do quality checks to watch the data. From those resources, we create both state-specific databases and nationwide databases. In this case here, I'm featuring the 3 types of state-specific databases. We have the inpatient database, ambulatory surgery, and ED, and we make that for each state that provides it to us under our partnership. To be a little more specific, I've got here some of the data elements that are included in the HCUP databases, including patient demographics, length of stay, admission and discharge status, plus those value-added variables that I described previously. And then I wanted to observe also that some data elements vary by state. So there's a core set of variables that we need to be able to access in order to build the HCUP databases, but where data elements are available inconsistently, we do try to pick up those variables where possible and include them as a resource to both be used intramurally and, if permission is granted, to release to the public. And so we are often working with our partners to enhance the race ethnicity data, which has gotten quite good in the last few years, or to include new variables like primary language spoken. Those are the kinds of things that we want to add when we can to the databases. From those state databases, we create 5 different nationwide databases. The top 3 are derived from the state inpatient database, the National Inpatient Sample, the KID Inpatient Database, and the Nationwide Readmissions Database. And I have the next slide, I'll give you a little more detail. And then 2 from the nationwide databases. The nationwide databases were the first product that we released publicly with partner permission, and they are sample databases that draw from the full set of the inpatient or outpatient data. And by producing something that is a sample of those discharges, it actually addresses a few issues, some of which are technical, but some have to do with partner relationships. So for example, if a state is, if one of our partners receives some of its operating revenue from database sales, for example, of their own state data, we did not want to compete with them by providing basically another version of their data, a full set of their data that someone would buy from AHRQ, and then the state would lose their data cell that they might need for operations. So that was one of the solutions of the sample. Of course, the database would be enormous if we had all the data from every state, but also it's not necessary for sampling because we have the universe, essentially the universe of community hospitals in the US, over 97%. It's also not necessary. But I wanted just to point out for this conversation that decisions are made not just about how to build the database technically, but also taking into consideration our data partners and what they would be willing to release. The NIS was the first product that we released, and I'll talk a little bit about how we distribute data in a moment. The other thing I wanted to comment on, because I'd heard some questions about this in some conversations I had with Joe and Norman Charles, is that the other benefit that HCUP can create for data users and from our data partners is that we add resources that you can use with the data to enrich its value. So I mentioned that we have reports and online query systems. We have a user support website in which we provide really detailed database documentation that is consistent across the databases and the types of data. We have technical reports that can help you if you're, dive into some data elements that you need to understand, to think about how to do trends, to think about maybe how not to do trends as you move from ICD-9 to ICD-10. We share the research that we're working on. We have an online query system. We do fast stats, which allows the user to do a very agile analysis online using the latest information that we get from our partners. We also provide online tutorials and training courses, and we also, normally we will go out in person and provide presentations. We've been doing everything virtually for the last year and a half at this point, but this is our goal. Our goal is not just to build the data resources, but to help others to use them and to facilitate the use of them. These are pretty complex resources, and we want to make sure that we're also enabling the best use and to share our best knowledge. We provide somewhat limited but technical assistance. We do have some limitations, but I think we respond to, and I say we, by the way, it's largely our contractor on this one, but over 40 questions a week just on technical assistance for using the data. And then the parts that some of you may be most familiar with, if you're users, are the HCUP tools and software, which provide a way to organize and analyze the data in a standard way. Perhaps the thing you might be the product you might be most familiar with would be the quality indicators, which were initially built from the HCUP data and in response to our partners' requests to have a consistent way to take a look at quality from one state to another, to a region, or to the nation. And these are either software tools that are downloadable or available online sorry, not, I mean, we allow you to download them. Some are just right off the website, and provide our expertise that we are sharing with our user community. And that allows for a fair amount of standardization. I think another part that's perhaps of a great deal of interest is, how did we organize the public release of the data? What I can share is that in the years before I joined the project, there was a lot of concern about not releasing data. I mean, back in the day, there wasn't a lot of that going on. There was concerns about protecting hospital identities. Of course, there's always been concerns about protecting patient identities. And for those of you who don't know, in HCUP, we don't collect any face identifiers. We don't have name or address other than the zip code of the patient. We don't have we don't have social security number. We don't have clear patient ID. We do an encrypted record number, et cetera. But over time, as additional databases got built and we started to really expand what we were doing, we had a lot of requests for users, and so did our partners. Our partners were getting requests from the public to get access to the data. And it was a kind of a patchwork solution. If you wanted to buy 3 years of data from 15 different states, you'd have to find the right person in the 15 states, find their application, go through their review process, complete that acquisition. So over 20 years ago, we developed the concept with our partners as part of our development to build the HCUP Central Distributor. And what this is an AHRQ-sponsored one-stop shopping for purchasing the state databases if the partner agrees. I'll explain that in a second, but the nationwide databases are released that way. So when you join the partnership, you do need to agree to allow your data to be sampled and included in the nationwide databases. But what we do, once we build a state database for every state that participates, and then we provide that data back to the partner. A copy is provided to them as well. If the partner chooses, they can make that database available to the public under the central distributor. They could elect to use the database exactly as we have it. They could create a subset of variables, or they might choose to group variables. For example, we will have all of the ages, but maybe in the file they want to release, they're going to group ages, or ages past a certain, elder, like past 85. Or, for example, AHRQ has the clear identity of the hospital, and we use that to do some of the linkages for additional data, but perhaps the state is not comfortable with the identity, so instead they might release characteristics of the hospital. Are they profit, nonprofit, teaching, non-teaching? Are they small or large? Are they urban, rural? So that is a decision point that is completely controlled by that partner. We make those state databases available. It is an online ordering system. The documentation is available. The state partner sets the price for their data. We will provide some background if somebody wants to know about, if one of our partners wants to know what's the price range that other people are setting, and we'll give them some guidance. But it is the decision about whether or not to release, what variables to release, what price to charge for that is a partner decision. But the benefit is that a user, a requester, can come into the HCUP central distributor. They can see in one view what data is available for what years with what data elements. They are required to take a brief online privacy training and sign a data use agreement. All HCUP data is released, all HCUP databases are released only with a signed data use agreement. And then we facilitate the application, the payment, the documentation, we hold on to the DUAs, and then the actual fulfillment of that order. And then we reimburse the partner on a monthly basis with any revenue. We report to them monthly, but we also reimburse them with any revenue that belongs to them. AHRQ adds a fairly small, we call it a handling fee. It's really just the cost of fulfilling that order. The nationwide databases are also released to this resource, but because they are a sample database, the review process is a little briefer, but everybody still has to apply, take the training, and send in a signed data use agreement. And I've included the website address here so that you can see if you want to follow up and see a little bit more about how that works. I thought you might also be interested just to see how the pricing works. The nationwide databases, those prices are set by AHRQ. They have gone up a little over the last 10 years, but I think extremely reasonable. We do have student prices. We can share, sometimes we make a complimentary copy available to another federal agency in HHS or elsewhere. But by and large, this is the picture, and state databases, you can see they vary in price. Sometimes that price, I understand, is set because of a state setting of a value, and sometimes it's really a business decision made by that organization. As I mentioned, we know that some use the sale of data for their operating budgets, and some it goes back to the state coffers, or they're not permitted to charge more than a certain amount based on their regulations or the setup of their organization. Okay, let me just pause for a second. Joe or Charles, are there any questions to answer before I go on?
I think from the chat, there was only one question that was about individual contacts, and somebody put in the link for that information. So I think we might be good, unless, Charles, you can see hands up that I can't see.
No, I don't see anything that you don't.
Okay, great. You know, I'm going to repeat something I said at the beginning while I was watching the various names pop up as you were joining the webinar. A lot of you have been working with the project for a long time, and I think it would be interesting to hear what you think some of the lessons learned from the other side of the equation would be helpful. And you know, there could have been an endless number of lessons learned, because we learn them like every week, to be honest with you. I thought when I was thinking about it, to me, the most important one was common organizational goals. You have to basically have be part of your mission. Part of your organizational philosophy is sharing information for research and for public health. And as a goal, I mean, what that really requires is looking for opportunities in the appropriate manner to get information out to the public. And you may have it at various levels, something that's public on a website, something that's available under review by a researcher, some different level of activity. But you know, essentially, we have to start from that position. And it's been my experience that over the years, that has been true across our partnerships, which is why we've had so many partners for so long. But fundamentally, we have to have transparency and trust. It is very difficult to communicate, especially now where people have so many emails every day and so many extra burdens, and staff are down in a lot of organizations. You've got a lot to juggle. We really have to work hard, and did at the very beginning. Each time we wanted to add a new component, a new database, a new way to show the data, more data being showed at a finer level, a host of things that we've developed over the years that we didn't start out with. We want to be able to clearly say what we're doing. We want to also say, here's the risk, by the way, you know, so what does this mean for you? Well, it means that users will have a better vision of this. And here's the reason why we think that's important. And here's the reason, here's the steps that we're taking to protect the data. And my personal perspective is that a lot of this has been based on relationship building and trust, especially in the first decade. And maybe, you know, less so now. We all knew the partners by name. We could speak to them regularly. We had meetings in person back then. We were able to do that, where we helped to develop new ideas. And the fact that we were forthcoming and that we're available to answer questions or be corrected if we had overstepped led to a feeling of trust, so that as we rolled out the next big idea, we tried to get input, we were able to get a fair amount of engagement. But kind of respect for the partnership is fundamental. I have to honestly tell you that almost every decision is balanced with, would the partnership be okay with this? So let's just stop and think, like, technically we could do it, but let's pause and ask ourselves, will this cause any issues for a partner? And we really keep that in our mindset, because as a voluntary data organization, if we disrespect that relationship, we're just not going to have the data and not be able to do the kind of work that we think is really important. And, you know, another philosophy, which is very hard to uphold, to be honest, is that both sides need to benefit. And I say it's hard to uphold because especially in the early years, I think there's some feedback like it's not a 50-50 partnership. And I think that's probably true. It's not 50-50. You all are out there, or the data organizations are really doing the grunt work of collecting and acquiring and finding all of your agreements and bringing all the data in and processing it. We're picking it up from that point on. But what we try to do for the benefit is we try to offer our tools, as an example, tools that you can use to work with your data. We do a lot of statistical briefs and try to offer it in a way that is useful for you to judge what's going on in your area. We sometimes put partners together. We share our technological ideas. We take technical questions all the time from a partner who might have gotten a question and say, you know, we're being asked to do this. Has AHRQ done this before? Do you have any recommendations? Sometimes we run data for them. So we are conscious of that. But I think maybe the one of the most difficult parts is that when you have a partnership and you have a combined product, think about our nationwide database. It is really difficult to find and negotiate every piece of that every partner can agree to. Right? And so that's a little bit of the next 2 points together. It is a very long process, and it's a very thoughtful process to figure out what is going to work for the majority, and then trying to bring, if you can, the last, the outliers together here. So for example, if you're building a nationwide database, you need everybody to agree to at least to a core set of data sets they're willing to release, right? But if it's something that's all or none, if there's a product you're trying to build that either everybody has to agree to or you can't go forward, then you've got to, you know, you may have some success with the majority, but you're going to have to spend a fair amount of time. And I guess one of my points, although I'm jumping around a little bit here, is that it's not always a limitation because someone is unwilling or uninterested or doesn't think it's of value. But as you all know, more so than ever, there's this real push-pull between releasing health data and data privacy. And so, you know, we have partners who have regulations that limit something they can release. None of us can do anything about that. So we have to figure out a solution to issues like that. There are different rules, and we respect that the organizations we're working with have to abide by those rules. So you have to be pretty creative in thinking about how you can build a product that works for everybody, how you can build a release. Can you all agree to the terms in a data use agreement? Because we have a shared, back many years ago when we built the central distributor, we worked together to incorporate and share with our partners what we would have in the data use agreement so that all of the partners could agree to use our common one rather than have 40 different data use agreements that had to be signed by each user. Another issue, which maybe not the nicest thing to say, but I don't mean it in a negative way, some in the chain of decision making may not understand your kind of data. And I know there's some people on this call who understand this. Probably in the last 5 years, as much as anything, there are a lot of decision makers in organizations about release of data. And they're well-intentioned and they know their area, but they really may not understand everything that's in your database and how HIPAA does or does not apply to it, what kind of a release risks identification more than what kind of release doesn't. And it's become more of a barrier lately to work with individuals who have an obligation to their own organization, but they may not really understand what's in the data, so they fall back a little bit to the protective. No, we can't release this. We can't participate in that. That won't be allowed. And you have to take a really long view and a patient view of having those conversations. If at the end of the day they choose not to participate, absolutely their choice. But it's hard to find a way to share a different perspective about what's in the data and what current rules allow, more broadly. And that takes me to that next point, which is you may not reach full consensus, right? People could really want to participate. They may want to be part of this project. There may be just one thing that the group is trying to do that they're just not allowed to do under their charter, their rules, their regulation. So you also want to build things that are both everybody has to say yes to be in it, like a nationwide database, or you can take whoever want to participate, like the central distributor. We don't need everyone to agree to release their state data. We just want to facilitate it when they're willing to do so through AHRQ. And so you've got, two means to get to that. The other thing that I found is you really need a champion or two. So when we work to bring a new partner on or to bring a new product out or new information out, we recognize that we really need a partner who wants to help us get that done. We've always thought of it as an extra burden to our partners. We know everybody's got more than a full-time job, and HCUP adds work to that job. And so we try to be really mindful, but the fact is there's some work involved. Agreements have to be reviewed. Maybe they have to be presented to a data committee. Maybe there are reports that have to be participated in, but if you don't have, you really need someone who wants to see this achieve. And sometimes the HCUP partnership just gets assigned to somebody, whether they want to be involved in it or not. Sometimes it's a great somebody who shared that organizational goal, is on board with the way that the data are to be shared and is really helping to move that along. The other point I wanted to raise is you've got to constantly be planning for the future. I guess what I have found is the minute you fill a demand, that gives somebody else a great idea for the next demand. So there's a need for more data, more timely data. You build the more timely data and say, okay, wait a minute. So you can do that now. How can you do it at this level? Can you add it at that point? And it's like, okay, here we go. So you've got to constantly be thinking about what's coming next. And I think that's particularly true of a partnership. You'll also want to start with the low-hanging fruit. What do we think most people can agree to first? What do we plan to add on? So it also gives a partner that if you're thinking of forming a partnership, some sense of where you're going next. So if they join at the beginning, they have a sense that there's going to be more an expansion of the project. And I think for sure you all have the same demands, no matter how fast you go. Obviously, and COVID is the perfect example for having required this. It should be faster. People want it more granular, particularly at the geographic level, and more capacity for linkage. And the challenge there is, of course, the worry about privacy and inadvertent identification. So I think this is just one set of lessons learned. I'd be interested to hear what other people say, but it is expensive. It takes a lot of resources, but I think, we feel that it has really been worth it and a really valuable component of what AHRQ has been able to do. Last year, we were able to participate within just a couple of months to provide information on COVID and hospital resource use, looking at what had happened in the past. We've assisted with helping to prepare for hurricane preparedness based on the data that we already had for longitudinal data over the years. We've been providing a lot of information on the opioids and substance use and neonatal abstinence, maternal health. These are really important issues, and the only reason we stand ready to do it is because we've built this collective partnership and data is comparable from state to state. So that is I don't know how fast I went there, but I'm going to stop sharing the screen just so I can get a look at what's, whether there are any questions or comments, but I'd be interested in other people's. Yep.
Yeah, so while you're doing that, we do have one question in the chat from Kyle Russell, and he's asking, are custom data sets available? If someone wanted, let's say, all cancer-related admissions across 6 states, could you ask for that custom cut, or do you have sort of predetermined data release?
Yeah. Well, we do not at the moment have what I think you're thinking about for a custom cut. So that is something that lots of people have asked for, or more people have asked for in recent years. What we have are you know, on HCUP.net, for example, you could use the nationwide databases and you could look at a particular diagnosis or procedure or condition or population and look at the aggregated data. You could look at it across years. We have a few of the central distributor partners are willing to entertain a custom ask. So in one particular state, and I actually just saw one this week, someone has asked for an additional variable that they don't normally release. The state partner reviewed that request, agreed that they were willing to release it, and we facilitated putting that data together. We don't have that custom availability, but of course, I know there's some demand for that.
Great, thank you. Thanks, Jenny, so much. And I realized, you know, that was an impossible task to take 30 plus years of HCUP experience and 20 years of your experience and try to crush that down to that amount of time. Thank you so much for that. We're going to now shift into asking our panelists a few questions as well. Hopefully that will stimulate more questions amongst you all as audience members. If you do have a question, you can put it right into that chat, or there's also the ability to raise your hand. So if you're not as familiar with Teams, just to the right, at least on my screen, of the chat button, there's a smiley face with a hand in front of it. If you click on that, that will let you raise your hand virtually. We can see that your hand is raised and one of us will point to you to ask your question. So while we are going to allow for that, we have 3 members of the audience who have agreed in advance to participate in this as a panel. We have Kyle Russell from the Virginia Health Information Organization, Kathy Hines from the Center for Health Information and Analysis, or CHIA, and Sterling Peterson from the Utah Department of Health. Each of our panelists are actively involved in their state APCD activities, and we are going to shift the conversation just a little where Jenny talked to us a lot about HCUP and the way that it's been built off hospital discharge databases. We are trying to figure out what lessons learned exist from HCUP that might be applicable to states that are doing APCD work. So we're going to take each of major functions of HCUP and ask our panelists to talk a little bit about their perspective on how that HCUP function might be important for state APCD developments as well. So I'm going to start with Kyle and ask Kyle, if we think about that development and distribution of HCUP databases that Jenny sort of finished on, from your perspective, talk to us a little bit about what you think the utility of something like that could be for a state APCD. And you're still muted, Kyle.
Hear me now?
Yes.
Okay. Okay. Sorry, I was on the phone, but then it's coming through my computer. So hopefully, can you still hear me all right?
We can. Yep, you're good to go.
Okay, great. Hey, everyone, Kyle Russell from VHI. We administer the Virginia All-Payer Claims Database, but then we've also administered the state's hospital discharge database since the inception of the organization back in 1993. I will start by saying we have been a partner with HCUP for a really long time. It has been a great partnership. We are just a huge fan of that model in general. And so, you know, since we administer both systems, we've gotten questions. We've always thought about, well, what's the applicability of this model to APCD? And we think that this is a huge opportunity for APCDs, something like this. And frankly, we've been sort of outspoken about that over the past few months. And I guess really the logic being that, you know, when some of the different federal legislation related to APCDs came up, we always contended, and I feel like the state APCD community said, hey, a federated model would be better. We think we could do a really good job at developing a federated model to look at different types of analyses from APCDs at a national level and provide that functionality, but still keep intact the great systems that we've built in all of our different states. And I feel like really the basis for that argument is the success of HCUP that we've had for a long time, showing that we can do something like that with administrative data. And so, I mean, I think the one of the good things about HCUP is, that Jeannie talked about is the flexibility, and that not everyone needs to participate in the same way. And, it's not, like I said, it's not an all or nothing thing. Some states might want to contribute some data, but not others. Maybe it makes sense to look at a national sample, but not all the different data elements. And so that not all or nothing approach, I think, would really lend itself here, particularly if we're thinking about how to get something like that started. We probably can't go from 0 to 120 right away, but there's these different steps along the way. But I feel like in Virginia, and I'm sure a lot of other states run into this, that we recently have been working on a request and a partnership with an organization that is using APCD data to do a lot of really cool research. And at the end, they said, hey, we're really happy with the process that we had in Virginia. We would love to replicate this in other states. What's the best way to do it? And we essentially said, well, you've got to go through each individual state and go through that request process. And they essentially didn't want to do it anymore once they found out that, if they wanted to request from 6 states, that they'd have to go through 6 different request processes. And, I think we probably all run into that where we participate in projects that the requester probably would want to participate with more than one state, but because of how it's set up, they probably don't. So we're kind of probably all leaving certain projects on the table that we would collectively benefit from if we had even just a little bit more continuity in the request process. So I think something like the HCUP model, again, we've been very clear. We think this would be just a great step forward, and we really want to advocate that, as states are planning out maybe what they want to prioritize their No Surprises Act funding for, that trying to do something like this and explore, even just a pilot like what may or may not be possible would be a really good idea and something we should explore.
Okay, great. Thanks, Kyle. And we can let Kathy or Sterling respond to that, or we can move on to another area or dimension. So Sterling or Kathy, anything you wanted to add to that?
I would just echo what Kyle said. I mean, we've been working with HCUP as well for years. And yes, back in the beginning, there was a lot of work to get to that point. And now it just happens. It works. People have the data. We are one of the states that Jenny's team had to come to and say, look, at this one applicant's looking for one piece of information that you don't normally give out. Can we do that for you? And we're able to accomplish that. It's just a phenomenal model.
Thanks, Kathy. Sterling, anything you wanted to add to that?
Sure. I don't want to derail the conversation at all, but entering this space, there are alternatives. For example, if you're using the literature on claims analysis, you see a lot of academics using things like Truman Market Scan, for example. I guess it's owned by IBM now, but so there are alternatives to these multi-state databases already there. HCCI is another one, right? So they pulled together a bunch of insurers and they've created a national sample. So I guess my comment would be, if you're pursuing this path, you need to make sure that you're adding value above and beyond what these existing databases already have, or you're tailored to a different use. Because I work for the state government in Utah, and this data isn't really designed to be like a state subsidized tool for market research per se. That wasn't the primary intent. So we need to, I think it'd be advisable to make sure that we're not appearing to compete with these large commercial offerings that are already there. Anyway, that's just something I thought.
That's a great point, Sterling. Thanks. So when we think about some of the other functionalities of HCUP, and we are sort of watching the chat and for hands raised, but while we're doing that, as Jenny mentioned, the distribution of data is one function of HCUP. There are others as well, and AHRQ has, among some of the other functionality associated with HCUP tools and software and supplemental files that get created as well. And Kathy, maybe you could start and talk to us a little bit about what you see as, potential needs and opportunities for states around what some of those sort of common tools could be that multiple states might benefit from as well.
Sure. So, one of the biggest benefits, I think, to having a national approach, such as AHRQ has with the HCUP project, is standardization. What's often said is if you've seen one APCD, you've seen only one APCD. We need a way to see the data at a national level standardized. So what does that mean? Things like standard service categories, standard insurance categories, disease categories, pharmacy breakouts, standard groupers, which HCUP does already, calculations done across states in a standardized fashion, PMPMs, benchmarks. I mean, the list is endless. And then once the data is standardized, what's next? Of course, there's the whole possibility of the distribution that we've just been speaking about, that HCUP does a wonderful job with. Maybe not all the states are going to be comfortable with that. It took a long time for them to get there with the hospital data. But what I really see is the big bang is cross-state reporting. Once you have standardization, just imagine how far you can pull that string. How do states differ or similar across things like PMPMs by service categories, insurance categories, fully insured versus self-insured, pharmacy information, enrollment reports across regions. What's the commercial, Medicaid, Medicare breakout in different areas? Geographic differences, rural, urban, how are they covered? Social determinants of health. And really, everyone wants to see benchmarks, 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 benchmarks. Could there be a tool that shows aggregate stats that would allow us to pick and choose which benchmarks, what subset, things like place of service, bill types, length of service by discharge, ER rates? And then once you pull that string a little bit further, how can that help us get the self-insured? If we can show companies, especially the large companies that are in multiple states, how useful this would be for them to compare healthcare payers' costs across their markets, provide standard reports that could be specific to employers, could be developed, I think that might help us in that area. And so I just, in conclusion, I think that this is a whole new world for the APCDs, and the growth potential is endless. I'm looking forward to hearing what others think and what other ideas and possibilities are out there.
Thanks, Kathy. Kyle or Sterling, anything you wanted to add to that dimension?
Yeah, we use the AHRQ software every year, and we love that software. It's a big part of our annual reporting, and if we have tools like that with kind of the ease of using that software and the variety of different outputs that we get, and frankly how easy it is to compare to national norms, like for something with claims, that would be awesome. I mean, I just feel like it just makes our ability to do more reporting and it's easier, and it just makes it more seamless. But then another thing that Kathy said that I really want to emphasize, because I think it's so true, a lot of times with claims, I feel like everyone struggles with how to interact with the employer community and how to engage them. And what we hear all the time is, hey, I'm in like 20 states. I don't, like, that's great. You can show me like just Virginia, but it's just the value proposition would be a lot stronger, I think, if we were able to show things with claims across multiple different states to these employers that are all over the place. Maybe that for the, since the risk employers tend to be larger, like that could be a real win for that too. Because like I said, that's probably the number one thing we hear on, like, hey, please opt in, like this would generate a lot of value. The common retort is like, yeah, but I would need to opt in all these different states, and I would want a multi-state report. So I think if we could address that, it would go a long way too.
Sterling, other thoughts about that, or other reporting as well that you think? I mean, that was another big part of what Jenny talked about, was some of this reporting that is that you can do because HCUP has some of the commonality. Can you talk at all about some of the reporting?
Yeah, so I mean, the reporting that we get back from HCUP, and she mentioned just they put out quite a few reports, and a lot of them are very timely. So in a state like Utah, where we have a very small analytical staff, we kind of lean on the results from HCUP. Oftentimes they're looking at national things, but it sparks the conversation where somebody will pick it up in our violence and injury prevention program, for example, and say, hey, can you look at this at Utah and maybe at the county level or sub-county level? So it really kind of primes the pump. It starts the conversation, and it allows us to also compare Utah to the nation and start to pinpoint places for improvement or places where we're doing well that maybe we can share some lessons learned. I can't say anything better than what Kathy said. Benchmarks, and everyone seems to be interested in how they stack up against another state, another area. Speaking in terms of like policy analysis, the legislative research staff are always interested in what's going on in other states. And if there was this type of resource available, that would allow that type of comparison to happen fairly quickly and more readily. It's like, well, these other states had these type of interventions. What do their PMPMs look like? Like, they have these different regulations. What do they look like? What was the impact there? Those questions are very difficult or impossible to answer. But if this resource was created, that actually allow the states to kind of broaden their ability to evaluate health reform proposals, and so that's something I'm kind of excited about. I think that could help inform. We'd be able to give better answers if we were able to interface with this type of resource.
Great. Well, thanks for that. We actually have, to sort of close out the session, we have an interactive poll that we're hoping that those of you who are on the phone would be willing to take a peek at. Charles is going to take us through that part. Before we switch over to that, I do want to say, thanks so much to Jenny for, again, trying to cram a 30-year history into 25 or 30 minutes. We know that's not easy, and it was super informative and very helpful. And to Kathy and Kyle and Sterling for giving us some reflections on the state as well. We are going to I'll shift over to Charles, who is now sharing his screen so that you can partake in the interactive poll, but we would like to get the take of the folks who are on the phone a little bit about where you think there might be utility of the multiple dimensions of HCUP that we talked about for state APCDs. So Charles, I will hand it right over to you.
Great. So I put the link to the poll in the, Norm did as well, into the chat. But you'll notice that you need to go to menti.com in your browser and enter the code 27629476. And then I am attempting to share my screen so that you all can see the results as they come in. Is that, are you seeing that?
Yep, it is working. Yep.
Okay, great. And yeah, so.
It looks like we've got, this data request process is coming up, the open source software and tools.
And you can do more than one, by the way. It's not just pick your most one. You can do multiple.
That's great. So to answer one of the questions that was in the chat, I believe that we will be able to distribute the slides that Jenny shared. We will confirm that and post them. And as you can imagine, this is not the end of this conversation. We wanted to get some of this information and then think about future planning work that might come out of this. It sounded like there were a number of lessons learned that Jenny shared around, while this is great, there were some challenges around data use agreements and agreements of those sorts of multiple states having to agree to certain terms. So I think that's one of the areas that that certainly has an opportunity for us to continue to have that conversation. So Charles, do we want to reflect for just a minute on what we see?
On the results of the survey, you mean, or the poll?
Yeah.
Yeah, it looks like, you know, the multi-state public information is, you know, out front, but with the kind of open source software and tools kind of leading the back, which that fit with the comments that we heard from the panelists, at least that I thought I heard. And yeah, and so, but it's interesting to see that there's a good distribution across all four of these types of functions. And I recognize now, though, that this not sure is probably a little bit underrepresented given the select all that apply option. So I apologize to all the methodologists out there.
Well, we are at the hour. We want to be respectful of your time. Thank you so much, everyone, for joining and for participating, and future conversations to come.
Thank you.
Thank you.